Good morning / afternoon, everybody, and welcome to episode 37 of the On Air Advocate. We're at the On Air Advocate. We look to provide education, support, and empowerment for all of those with different abilities, mental and medical illnesses, and their caregivers. For those of you who do not know me, my name is Tammy Flynn, and I'm the host and producer of the On Air Advocate. And I am super excited that you guys are joining us today, whether that be right now on the live or whether you're catching this on the replay. Now, as most of you know, we are engulfed in our series of chronic pain and pain management. And so if you think that this broadcast could be beneficial for anybody, please hit the share button and give us some love. In addition, if you've been following, we've had 2 weeks of all different perspectives on pain management and chronic pain. And so today I am super excited to welcome back our favorite pharmacist. Now, she's not my favorite this morning because it's 85 there and it's 37 degrees here. But our favorite pharmacist from Georgia, Cynthia Hendrix. She is a health educator as well as a pharmacist, and she's also the producer of the Pharmacist Answers podcast. So welcome back, Cynthia.
Thank you for having me back. It's been a while, so I'm excited to
get back into it. I know you were doing a whole remodel the last time that
the microphone had to go for repairs. It was quite dramatic. So
there was lots of things going on, but we are back. And so we're sorry for the delay as well. Another thing that happens too in this whole live world that we were a few minutes behind this morning. But really, I wanted to dive in with you. We've had so many different perspectives this week from, the doctor's end of things in the clinical setting to people who provide supports outside of that for chronic pain and people that are actually dealing with chronic pain on a daily basis and kind of their journey. So from the pharmacist perspective, lay it on us.
Yeah, sure. And I'm sure everybody that you've listened to and talked to so far, pain is a subjective condition that we deal with. Everybody's pain threshold is different. Everybody's description of how certain types of pain or certain types of injury that cause pain may feel and how they try to describe it and communicate it. So it is very complicated and then also very personalized because pain can be a very personal condition where it's hard to describe what you're feeling, but you're feeling something and you're trying to communicate it in the best way possible for a physician to help you or for your family and friends to support you. And so that in itself makes it very difficult, a very difficult field of medicine in that there's so many things that we understand and we're like, well, either it hurts or it doesn't. That should be simple to fix, but it's really not. And so when people come to me at the pharmacy and they go, I've been taking this pain medicine and it's just not working. I don't know why my pain medicine isn't working. I have to look at a couple of different factors, and some of it is simple and some of it is information I can find in a textbook, and then some of it is more subjective because each individual is different. So starting with the textbook stuff, generally when I try to explain the different classes of medications that can be used for pain, I see them in kind of 3 categories. And one is anti-inflammatories. So the inflammatory processes in your body, and there's like a gabillion different chemical signals that your body sends in relation to inflammation, and an immune response, quote unquote, that is hard to target. But the inflammation in your body will generally, one of those chemical signals will generally translate to pain in your brain. And so if we can remove the inflammation or turn off those chemical signals, then that's going to remove pain. So anti-inflammatories, we've got NSAIDs. That's your non-steroidal anti-inflammatories.
Like things like, so for the lay person listening, what would some of those things be, like ibuprofen, right?
Yeah, ibuprofen, Aleve, which is naproxen. You've heard of Mobic or meloxicam, diclofenac. There's a bunch of them that work kind of in that same pathway to remove the inflammation signal or turn it off so that that inflammation stops. And then The other, if we've got non-steroidal anti-inflammatories, then obviously steroidal anti-inflammatories. Steroids work on a bunch of different processes in your body, and one of them is the inflammation process that happens.
So would we look at those like most commonly like prednisone?
Mm-hmm. Yeah, I've
Think of
seen
that?
people who have gone through like workplace injuries. You end up on workers' comp and end up out of work for a little bit.
Right.
And one of the things the doctors will do, one of the things I see a lot for acute injuries is like a Medrol dose pack. So it's the little pack of the steroid that has like, you take 6 tablets for the first day and then 5 for the next day, and 4, 3, 2, 1, and you kind of step down, because you really hit the system hard with something that's going to turn off those inflammatory and pain receptors. And then because they're steroids, you kind of have to like step off of them gently so you don't turn into like the Incredible Hulk and want to.
So is that why they changed that? I don't mean to throw you off on the subject, but I've noticed that over time, because my son, 20 years ago, when he first started, obviously when he was born and all of his illnesses, we were on prednisone a lot, and they never had that staging. It was like you were on a straight amount of prednisone for so many days, 1 tablet or 2 tablets, per day, or so many hours. And now when I've seen people get steroidal, stuff, it's all in those packs, and it's going like 6, then 5, then 4, then 3, then 2. Why is that? Why is that across the board? They've kind of changed it, or is it just what the doctor likes to utilize better, or like a regular? I mean, what do you see more of?
Yeah, that's a really good, legitimate question, and a lot of it is doctor specific. Sometimes it has to do with the length of therapy.
Okay.
So if you're on, like, for people who may get bronchitis related to like all the allergy and pollen stuff that we're dealing with right now, the doctor will be like, okay, take 3 days of prednisone and then just take your allergy medicine. Well, 3 days of prednisone probably isn't going to be that big of a deal for your body, like going on it and then coming off of it. But a lot of times, if there is a situation where you really need to hit the system hard with a steroid to get the type of response quickly that you want, then to come off of a high dose like that just immediately, the body has a rebound response. And for a lot of people, that because the steroids kind of blend over into like how your hormones are made in your body. You make natural steroids in your body. They're generally hormone based. So because that is a blended line of, we're giving you a steroid in a pill, but your body is also making some of its own, then a lot of the rebound response is hormonal, which then, depending on the person and depending on the gender, male or female, you end up with a strong emotional response in a way.
Okay.
I've known people that if they come off a steroid cold, they end up super paranoid and just like all of this weird stuff, and it lasts for 3 days, and then their body, balances out and equalizes again, and it's fine. But for some people, they're just like super grouchy, for especially for males who are testosterone based. They end up very angry and very aggressive in the response coming off of a steroid. So a lot of times they've just kind of learned, for your sanity and the sanity of all the people around you, it's easier to just step you off gently rather than be like, here, take 32 milligrams and then stop.
I just know that 20 years ago or even 15 years ago, I never saw that. And now I see it more in friends that get prescriptions, or when my son has gotten a prescription, I'm like, what's this? Like, why have they changed the kind of the model of that, of the way that?
Yeah, and it's just a matter of being more comfortable. Like, you're like not shocking your system so much. Like, sometimes when you're injured or you're sick, you kind of need the shock to the system with putting the steroids in to get the response and get the ball rolling in the right direction for removing inflammation or helping fighting an infection or something like that. But you don't want to shock the system when that suddenly goes away. So you end up with a gradual step off. And so those steroids are used for inflammation pain. So if there's any type of injury or pain related situation that they know inflammation is involved, one of those types of medications, either the non-steroidal or the steroids, will be used for that type of pain. Another type of pain is nerve pain, or we call it neuropathy. where the nerves are sending signals to the brain saying something is hurting.
Okay.
Sometimes if that something is hurting is legitimate and there really is something hurting you, then that's why the signal was put there in the first place. But sometimes the nerves may end up with permanent damage, or they may end up with some type of chemical imbalance that remains after the injury and the trauma and the initial assault is over. Then there may be a chemical imbalance related to those nerves that they continue to send signals, even though there's really nothing like offending them in that moment.
Okay.
And so, so that happens a lot we hear neuropathy a lot when it comes to diabetics, because the sugar in their blood being difficult to keep balanced and under control sometimes leads to the small nerves in their teeny tiny parts to become damaged more quickly. So the damaged nerves in the teeny tiny parts like fingers and toes and the eyes will start to send signals because of that damage, and that those signals will be out of whack. Even though there's nothing actually stabbing your fingers and your toes, you may have a stabbing or tingling or prickly feeling in those parts because of that nerve damage. And that it also happens in bigger nerves. So if you have like a spinal injury, then there's nerves, which are the big nerves that control big parts of your body, come out of your spinal cord and go to all of the places they need to go. And if there's a spinal injury with the bones in your spine, then those nerves kind of come out of all the different holes. And if they get damaged, either temporarily or permanently due to a larger impact or injury like car wrecks or falls or things like that, then those nerves can then start sending wacky signals to the brain when nothing's really happening to them, or because they're constantly injured. Because if it's being pinched, you've heard of a pinched nerve. If that nerve is consistently being pinched, then it's going to continue to send a signal until it stops being pinched. And even if the pinching of the bones and the disc in the spine is alleviated, if that nerve was damaged permanently, then that signal will not ever go away. So with nerve pain, the funny thing is, and I have to answer this question a lot, is people go, why did they give me Depakote for my nerve pain? Depakote is a seizure medicine. And Depakote works in the brain to help balance out and re-regulate nerve signals. And so if you think of nerve pain as little micro localized seizures in those nerves, then it makes sense that a low dose of a seizure medicine would kind of help rebalance out those chemical signals from those nerves. So they'll only send signals when they're supposed to, and then when they're not supposed to, they'll just like turn off, which is the same thing you want to happen in a seizure. You don't want the brain to be sending signals when it's not supposed to be. So the seizure medications help rebalance out those signals and those chemicals in the brain, so the seizures will stop.
Of the muscles.
Muscles. So with nerve pain,
side effects, when we're talking about obviously that's much more of a strong medicine than like taking a little bit of ibuprofen. No, I'm not saying taking a lot, because ibuprofen,
and it's more specific too. You're not like ibuprofen. You can kind of know if you're, you twist an ankle, you get a little bit of swelling, then you can take an anti-inflammatory. When it comes to nerve pain, you can't be like, oh, let me go get a dose of Depakote and see if it'll work. Because the other thing too is those types of medications have to build up in your body. So it's generally not an acute thing where you just take it for a short period of time and then it's over. You have to take it for a week. For neuropathy, you're generally on a medication for a longer period of time, or the rest of your life, depending on how bad the damage to the nerve is.
But what kind of side effects does something like that have? Or it doesn't that have that many side effects?
Well, a lot of times they're using much lower doses. And Depakote is a unusual example, but it is used a lot of times, and people go, that's a seizure medicine, what's going on? And it'll be used in much lower doses than what somebody might be using for seizures specifically. But gabapentin was originally developed as a seizure medication, and it was administered in really high doses. And now people are using 300, 600, 800 milligrams at a time. That's a much lower dose than what was initially required for like full brain seizure control. But they know that it does help with those localized misfiring of the nerves in smaller body parts. And I say smaller or more localized body parts, where if it's like in your spine.
Right. Yeah, my son took that for quite a long time, gabapentin, but we finally, after spinal surgery, we're off of everything. No more gabapentin even. I mean, he still has neuropathy in his legs and bother, but can tolerate it, you know?
Yeah, and sometimes, you know, nerves kind of come and go. You know, if it's something that kind of comes around for a couple of days because of overuse or extra activity that you're not used to doing, then generally a lifestyle modification will alleviate it, where you rest, you know, you plan better for the next activity, something like that, versus just like having to take medicine. But yeah, so nerve pain is one of those weird things that can accompany an injury or other types of pain, or it can be the main type of pain that sticks around after everything else is seemingly medically fixed. You know, you're not being crushed anymore, you're not being injured anymore, nerves aren't being pinched anymore, but if that nerve maintains any kind of scar tissue or permanent damage, then it's going to consistently send a signal as if it is being hurt for the first time over and over and over again. So having a medication to kind of turn that signal off, to tell it to be like, chill out, be quiet, you know, nothing's wrong with you, then that can be something that a person has to be on for a long term. And then the third type is what I call endorphin regulated, or the receptors in the body. They're called mu receptors or mu opioid receptors, and mu being that Greek letter that, because they name all kinds of things in medicine and chemistry with Greek letters. But those, it's endorphin based, and your body makes natural endorphins that have a similar chemical structure to what opioids are able to mimic. And so this is the type of pain that may require an opioid to treat if the body can't create its own endorphins and get over it quickly. There are types of pain where you hurt, your endorphins kick in, and then it doesn't hurt anymore. The one we may be familiar with is like childbirth pain. You have childbirth pain, your endorphins kick in, and then like the thing that's causing you pain is over, and then your endorphins like wear off, and then you're fine. But there are times where there may be an injury that the endorphins may kick in when it initially happens to try to alleviate the pain. And it's one of those times where when traumatic injury happens and you're like, oh, it really doesn't hurt that bad because your endorphins and your adrenaline are kind of running. And then when all of that wears off, then the pain on the scale just skyrockets and it becomes excruciating. Your endorphins are your natural pain relieving cycle in your body. Like, your body has a natural system to do that. But if there is an injury that leads to permanent damage surrounding those specific endorphin receptors, then an outside or a synthetic endorphin mimicking medication may be required, and that's where opioids were created. And so that the other thing is, because the endorphins are kind of your feel good part of your feel good system, that reward system. That's the other reason why the opioids can become so addicting, and people actually desire to take them, because not only do they make the pain go away, they kind of make you feel good, because your endorphins kind of make you feel good. Some of that making you feel good is to trick you into like forgetting about that you were hurting for a minute until the body can heal itself. But because of that reward system, it makes endorphins, your natural endorphins, and then any synthetic medications that mimic the endorphins, highly addictive. Because even with people who are, we call them adrenaline junkies,
Mm-hmm.
they get that natural rush of endorphins and adrenaline. And so they're always seeking something else to be able to get that natural rush from their body versus putting something, man-made in their body. They're just going out trying to find an experience that will allow their body to produce it naturally. So
Okay.
those types of chemicals, your brain likes them. They make you feel good, and your brain and your body likes feeling good. So it tries to trick you into doing things that will make it feel good.
Now, where do you find, I mean, it seems like it becomes very complex for those that have like a chronic illness, that leads them to like having juvenile arthritis and things like that, to come up with kind of a mixture that fits, because it's this lifelong pain. It's not like I get injured, I got a back injury, and now I always have this, little bit of chronic back pain. It's something that is so muscular, for a lifetime. And so, in your field, do you think, I feel like treating that, do you think they're just as equally as hard to treat, when it's an insult, like an injury type of a pain, versus somebody who has a chronic illness?
I think any type of pain is hard to treat, even with like my children who are 3 and 5, and they go, "Mommy, my foot hurts." Well, how does your foot hurt? What made your foot hurt? And trying to get another human being to communicate to you, even if they are a grown adult, well educated, trying to get them to communicate clearly what made them hurt, what does the type, like, how does it hurt?
Right.
We like to describe certain types of pain. Is it burning? Is it stabbing? Is it throbbing? And a lot of that is very complex,
Variable.
convoluted. Yeah.
Yeah.
So the ambiguity of describing pain, even to a trained medical professional, is a huge hurdle to get over. And certain chronic conditions that have pain as one of their main symptoms will also have other markers. So for juvenile arthritis and for rheumatoid arthritis, there's markers in the blood. You can have a blood test done, and there are certain inflammatory markers that show up to also indicate that a disease process is going on.
Okay.
And so and same thing with the other thing is there's a lot of imaging that goes on when it comes to people who go to the doctor with a complaint of pain. Obviously, if you're injured in some traumatic situation, a car wreck, a fall, a sports injury, something like that, they're going to be doing imaging. They're going to x-ray you, they're going to MRI you, they're going to CT scan you, they're going to do all kinds of things to look at all the different parts. If they're needing to look at bones, if they're needing to look at muscles or ligaments or cartilage or the disc and the nerves in your back, there's going to be imaging to help try to see what's going on the inside of you without actually cutting you open.
Right.
And so through those types of things, they try to get an idea of what's hurting you, why you're hurting, and what they can do to make it stop. One of the most frustrating things that I see right now is that a lot of people are coming through with a diagnosis of chronic pain syndrome. But what does that mean?
What does that mean?
Chronic pain for you and chronic pain for me may affect different parts of our body, different areas of our life and our ability to perform activities, but then we get lumped under this one umbrella of chronic pain. It's
right.
not.
And then do you find that doctors are just prescribing kind of that same, this is the diagnosis, and giving the same medication?
And that's one of the things that we're finding, is that at least as the pharmacist and the professional decision maker in the pharmacy, when the prescription comes through, there's things that I have to do because at least the state that I live in and a lot of other states in the country put a burden on pharmacists to make sure we're only dispensing medications for legitimate medical purposes. But when they allow a poorly defined diagnosis of chronic pain syndrome to go in the books as being an official diagnosis, I'm going, well, I don't know what this means.
Right.
But so one, I either get to be really nosy and ask you a lot of questions about how'd you get hurt? How long have you hurt? How long have you known this doctor? How long have you been on this medicine? Those kinds of things. To make sure that my job isn't at risk.
Right, because I think what people don't understand is you're kind of like that next gatekeeper. Like sometimes people don't understand, they go to their doctor, but there are amazing doctors, but there's also doctors that, might be a little bit on not the amazing side. And
yeah,
so
it's true.
You're like the next gatekeeper to go through. And so I can just imagine people's intolerance or irritation level with you when they're coming in to get something, and you have to be like the next door. Especially if they truly are having pain,
right?
But the only way to control, I can see how that can become an issue. So what happens if you ask them all those questions? What's the other alternative if you think something doesn't seem quite right? Is that when you have to have those conversations with the actual doctor?
Yeah, a lot of times if I can't get sufficient answers from a patient, then my next step is to talk to the doctor staff and maybe the doctor themselves about what are you treating them for? How long have you been treating them? Do you get like updated x-rays or MRIs to evaluate the progression or the improvement of this injury or damage or whatever? And there comes a time where I get to decide, yes, in my professional judgment, this is a legitimate need for this medicine, so I'm going to dispense it. Or if something comes up as a red flag and I can say, I cannot, with all the gut checks I've had, I cannot fill this prescription and feel right about it. So, and then I have to refuse people. And that's hard because my job and just my personal tendency is I want to help people. I want people to feel better. But I also have to look at, I can't be naive. I can't believe everybody's story. There's going to be people out there that are going to try to lie to me, patients, their families, the doctors, they're going to try to lie to me to get what they want. And I have to pay attention. And so, because there used to be a time where if the doctor said so, then you just did it.
Right.
Society as a whole trusted doctors almost more than their preacher. If the doctor said it, I'm going to do it. If the doctor said take it, I'm going to take it. And we're reaching a point now that we kind of see the money and the greed that's behind a lot of medicine. And so society as a whole is kind of taking a step back to say, one, they're really looking at the benefit to them as a whole person. So they're looking at for more natural ways to take care of themselves, or more natural ways to treat what's wrong with them. Because there's kind of a divide. We've got people who have lived long enough and they learned better too late. So now we got to figure out how to take care of them with the diseases that we've got. And then we've got the other side of the divide where it's the generation that they're not sick or injured yet. So they're trying to do their best to stay not sick and not injured by using natural remedies and taking better care of themselves. So, which is a wonderful thing. If people could get well enough and it put me out of a job, I'd find something else to do, I promise. But I don't see that happening in my lifetime. So I'm gonna care for people in the way I've been trained in the best way I know how. But people have kind of taken the step back of not trusting doctors as much. One, because they've seen them get really greedy. And they've also seen them get kind of this God complex where they think that they are the gatekeeper of whether you live or die, and that's not always true. And they've reached a place of greed and ego that they think they're above the law in some ways. So they're looking for what's going to write them the biggest check. And if writing people pain medications that they don't really need is going to get them the biggest check, then they kind of turn into a green-eyed monster, and you can't trust them here or there. So so that becomes a difficult place. And I even had a recent conversation with the doctor himself, and these are some of the things that I kind of look at. Is the doctor easy to reach, or is the doctor too easy to reach? So if you bring me the prescription and I'm like, I'm gonna have to look into this a little more, give me a few minutes, and then you go sit in my chair and then text the doctor on his phone to be like, hey, that pharmacist is about to call you about my prescription. Do you think I'm going to fill that prescription for you? Like that's too easy. That makes me think he's doing you a favor, and you don't really need this medicine. Because there's a lot of laws about doctors writing control medications all across the board, not just pain medications, but any type of control medication for friends or family members, or writing them on their prescription pads when they're off duty. There's all kinds of regulations and laws that stop them from doing that. And if we find out that they are doing that, then I, as the pharmacist, have to say, no, I'm not going to fill it. And then if they do it too much, they can be reported to the medical boards. But there's, and that's why I feel like it's so important, no matter what disease or chronic condition you're dealing with, it's always important for you to have an open relationship with your providers, with the healthcare professionals that are taking care of you. And that includes the doctors and the nurses and the pharmacists who are dispensing your medication, and any other practitioner that you have that may be performing naturopathic medicine, or your chiropractor, or whatever that bubble of healthcare professionals that make up your team to take care of you. Having a good relationship with all of them, and then making sure they have some type of relationship between them. So it's one
would
thing.
You say that in that relationship team, you're, especially if you are someone that has chronic illness like since birth, or an onset for many, many years, that those same doctors also have a relationship with you as the pharmacist, to make sure that the pharmacist is kind of part of that team, because there is so many roadblocks when it does come to different medications, so that, that patient is never without what they need in some of those serious pain situations, but it's also very, very monitored as well.
Right. And they get to double check each other, because especially if you've got conditions going on with multiple organ systems in your body, you're going to have somebody looking at your heart, and you're going to have somebody looking at your brain, and you're going to have somebody looking at your bones, and they all have their specialty, but they all, like, the circle needs to connect on the outside. They don't just need to connect with you as the spoke in the middle of the wheel, but they need to be able to communicate with each other. And I'm much more open to doctors who I know are local and accessible to, if you're a doctor in my community and I have lots of patients seeing you, and there's even the possibility that I could go see you if I needed to, that's an extra layer of relationship and an extra layer of protection than if you're 3 hours away from me and I don't know you from Adam's house cat, and you're writing prescriptions. Like, how can I trust you? Because the doctors that are local to me, I'm probably seeing multiple prescriptions from those doctors for multiple people, and I get to see, are they tailoring the therapy for each person to that individual, or are they just writing the same medications for all 30 people that come through their doors in a day? And those are some of those red flags where if they just kind of have this, they've actually labeled it now in a lot of the federal investigations and like this opioid epidemic that's going on and in the news, that, they've taught us to identify cocktails. So it is, if the doctor writes drug A, drug B, drug C every single time for the maximum amount that the person can have, then they're like, okay, that's a cocktail. So they're either getting really high off of it or they're selling it for big bucks on the street. And so being able to identify that, and we've even got some doctors who are just nervous about writing certain types of medications, period.
Mm-hmm.
And they say, I'm not going to write that. You're going to have to go see a specialist for that. And so the fear and the lack of regulation, or the regulation placed in the wrong direction,
right,
is really starting to limit patients' access and damaging their trust in the doctors that they've been seeing for a long time, because medical boards and even the federal regulations and state regulations, because there's multiple levels of law. We've got the federal law that kind of rules the nation, and everybody has to follow. And then each state gets to make its own set of laws to decide if they want to be more strict about certain types of situations. And then there's the medical boards that give all the doctors their license. And because they have been very slow in making regulation changes of what needs to happen with pain clinics and treating people with legitimate pain, whether it's short-term pain or chronic lifelong pain, because people fall in both categories. You break your leg, you're probably going to need to see somebody and like take care of that injury. But once it gets better, you may not be in pain at all ever. You're in a life-threatening car accident and you may be damaged for life, and it changes your quality of life. It changes your ability to do things, and you're going to need treatment for the rest of your life. There's genetic and debilitating conditions that you may just draw the short straw, and that's what you have to live your life with. And you need trusted caregivers and medical professionals taking care of you, and not being limited by all the dumb people who are trying to be mischievous and skirt the law and like sell drugs to teenagers and all of those things. Like,
but I think it's eye-opening. It's so eye-opening for you to present this, because so many of us, if we're in need of something, first we have to wait for the appointment to get to the doctor, then you get to the doctor, then you finally get the prescription, and then when you get to go to the prescription, sometimes the insurance doesn't cover it, or your second insurance doesn't cover it, or they're fighting over it, or the pharmacist is like, especially if it's a substance, I need your ID and I need this, and you have questions. And so for those people that legitimately are in need and are doing it in good faith of all the things that, what I'm saying, of all the components and crossing their T's and dotting their I's, it's a frustrating thing. But when you talk about it on your end, you can see why it's so needed in our world, because how else do you even start to control something that's completely out of control?
Right. It is. And because legislation and the board regulations have moved so slowly in making a decision on how they want to handle this, insurances have like closed the gate and they're like, you get 7 days of Norco and that's it. And you're like, okay, 7 days. So I have to go back to the doctor every 7 days. So like, because those types of medications can have refills on them. And we're seeing this gate slam over and over and over again as insurances are saying, since they're not going to control it on their end, then you could write 30 days worth of medicine, but we're only going to let you have 7. and so
how do you deal with something like
that? And so the message pops up on the computer and we kind of go, what does this mean? And the patients are looking at us even wide-eyed like, I can only have 7 days, or I have to pay cash for the entire thing, because a lot of those medications, because they're not allowed refills and they're not allowed to be phoned in or faxed in a lot of states, like either you get the entire thing or whatever amount you don't get is forfeited forever and it's gone.
Right.
And so, we're looking at these things going,
There's just a lot of pieces of the puzzle that don't come together.
Yeah, you're trying to regulate it, but this is not the way to go about it. You know, and it's, and like patients, you know, us as the pharmacy team, and even like my technicians who deal with insurances all the time, you know, they're looking at it and they're going, this is a terrible decision. Or the only way to get around it is for the doctor's office to submit a prior authorization, which you probably had to have prior authorizations for 100 other things too. Here's just one more thing. They have to submit a prior authorization to say there is a legitimate reason that this person has to take this pain medication for 30 days straight with no breaks in between. I guess that's weeding out the doctors who, if your doctor legitimately thinks you need that medication and legitimately cares that that's going to improve your quality of life and improve your condition over the long term, then they're probably going to be willing to do that prior authorization. And it's weeding out the doctors who are like, either do what the insurance says or pay for it out of your pocket. Those are probably also the doctors who just take cash patients and they don't bill insurances for your appointments anyway. And that's like a whole nother can of worms when it comes to what doctors do I trust versus who do I think is kind of like just open a doc in a box to start writing people prescriptions. And I don't like having to profile people.
Right.
You know, I just want to take care of people. I've always been more positive than negative, and I'm more willing to put trust out there than probably is best for me. I could probably be better off if I didn't trust as much as I do sometimes, but it's one of those things that if I have to choose you being hurt or your care being roadblocked or me dispensing you medication, I'm going to make sure you're taken care of. And that's why, again, even with the patients I see on a daily or weekly basis, I'm always emphasizing, you got to have a good relationship. You got to make sure that doctor has a good relationship with me, or at least my team. You know, I'm not there every day, but you know, you got to have a good relationship with somebody on my team. And then you as the patient having a good relationship with your pharmacist. Like, don't just be the person that pops in, like grabs stuff and leaves, because if I get to know you and I get to know your story, then the pieces are going to click of why these medications are needed, whether it's a chronic condition or a traumatic injury that left permanent damage, or whatever the reason is for the pain. If you have that patient professional relationship, then you're gonna have a better chance of getting everything you need. And maybe the roadblocks won't go away, but they'll feel a lot smaller because you got people working for you and not against you. You don't want your pharmacist to be the roadblock. You want your pharmacist to help you get over the roadblock. And because we're looking at all of these people being delinquent, the doctors, the patients, their families, these drug rings that the feds are trying to get rid of. And in Georgia, we had a big issue with it for a while. And we were told by, so the U.S. has the DEA, and they're kind of like the drug cops for the country. Each state and a lot of states will have their own state organized, like drug cops to kind of monitor things in their own state. And we were having our agents tell us, they're like, if this patient isn't local or the doctor isn't local, then you don't need to fill these prescriptions. And we kind of have to follow a similar rule that if the doctor is so far away from us and we know that the patient is willfully passing 2 or 3 or 4 other doctor's offices to get to that one doctor, and they're not a super specialist of some kind, then it's going to raise a red flag to say, if you're going to see that doctor, then you need to fill out a pharmacy that's going to have a relationship with that doctor. And so that's where the relationship really comes into play. And there's times if you travel, like, pain shouldn't be something that limits you. You should still be able to live a life that you want. even while managing your pain, just like managing any other condition that may require more attention or more planning, but it shouldn't stop anyone from being able to live their life. So you shouldn't be afraid to travel with pain medicine. I think there was another time we talked about, making sure like if you go through TSA, like making sure you're following the rules, having stuff in your purse and all of that stuff.
So that you have it along with you. But I think you make a very good point and make it clear to people. I mean, there has to be some gatekeeper at some point. And though so many of us are doing it in, you're getting it in good faith and you need to get better and need to control that pain, you understand why good doctors and good pharmacists kind of put up a little bit of a wall and ask those further questions. And you can't get mad at somebody for doing that when you look at what's going on in our world. I mean, it's the only way to keep any control. And I think I talked to you about this a little bit when me and you have had our private conversations. After my son had full spinal surgery, he was on huge amounts of narcotics, for the pain. And he already has neuropathy in his legs and other things. So he was in a pain clinic already and going through that process. And myself, so I administer all the medication to him. I give him all the medication. And we came home after being in the hospital for over 3 weeks. And, we were still on, Oxy, and we were still on, I'm saying some of the different narcotics. And, you're supposed to try to wean and you're supposed to try to figure out, well, how much pain is it? And is it really pain? And it all becomes, after a while, very foggy, doesn't it? Like, am I experiencing pain or do I think I'm experiencing pain? Because when you're on different types of narcotics, I think you get that fogginess about you and not knowing. And when you have somebody administering it, to you, I think it's helpful for someone to look and say, I think we need to start to back off of this, a little bit. But what if you were an adult and you were doing that yourself? And so it enlightened me so much to think, at that point, he was in so much pain. If you have a tremendous back pain, or you were in an accident and you injured your whole leg and you're in this tremendous pain, how do you ever, as an adult, administering it to yourself, regulate it without developing an addiction to it? You know what I'm saying? It's very hard when you don't have another person that lives with you or a perspective that says, hey, I think you're getting a little weird. Like on this, or you're utilizing it a little bit too much. It's a very fine line is all I have to say.
It is. And there is a documented phenomenon that happens with opioid medications in particular, and it's called hyperalgesia. And it's essentially where opioids will, over time, lower your tolerance to pain in general.
Interesting.
So for people who have a really high pain threshold, and women like me who have babies with no pain medicine, like that pain threshold is really high.
Right.
And so there's times where if there was ever an instance that you needed opioid medications legitimately for an injury and a level of pain, over time, your sensitivity to pain will lower, so that what used to be a level 3 pain, so you got the pain scale and it's like 1 through 10. So what used to be like a level 3 pain, your body is going to translate it as level 7 or 8.
Okay.
And so that is something that, one, if the doctor's a good doctor, he's going to educate their opioid patients about, saying this is going to happen. So if you ever have to come off this medication, this is going to be a real thing, and you have to work through it, because it's not permanent. It's just as you start coming off the opioids, that hypersensitivity to small pains and just small twinges gets translated as a much higher, much more severe pain by your brain, because that sensitivity scale has been altered by those medications.
Right.
The other thing is that because the opioid epidemic is so hot in the news and has so many people hot under the collar and riled up in different camps and for different reasons, the line between addiction and dependence has been blurred. And addiction is generally has a root that is more emotional and rooted in brain chemistry and behavior, where dependence is just the body's biological response to having something that it liked being taken away.
Right.
So caffeine is a drug.
It is.
And while we think it's funny to joke about having a coffee addiction or a caffeine addiction,
it's a horrible thing because you can't stop it.
Right. It's more of a dependence.
Yeah.
Because your body gives you a really bad response when you don't have it. But generally, your connection to coffee, no, some people do have an emotional connection to coffee, and it's by choice. But the emotional connection to opioids, to alcohol, to pornography even, that's not a drug, but it messes up your brain chemistry bad. The route that sends you down that path to possibly become dependent on those things, but flips over into more severe and being labeled as an addiction is more emotional related. Because a path down the road of being hooked on pornography may be dealt in loneliness and rejection by peers or society. Same thing with being on cocaine, may have to do with trying to alter your view of society, or addiction to alcohol and alcoholism being rooted in the fact that it was triggered by depression because of rejection or wanting to alter your view or numb your status in society. Right. Where dependence is specifically and solely the biological, chemical changes. Addiction is more rooted in the emotional web that gets tied around why you started down that path in the first place. Right. And so dependence, we can generally get you through the dependence path with medication. If there was ever an addiction and an emotional component to going down a certain path, with illegal substances or overuse of opioids or any other addictive abusive substance, that's going to require a lot of more therapy that I'm not qualified for. Right. And the other thing too is that pain in itself is very complex, in that it's not just about the physical hurt. Pain can affect your emotions. Pain can affect what they call whole pain. There are secondary medications that may have to be used because of pain. We know that pain at a certain level, if the pain signal in your body is high enough, it will also trigger a response in your blood pressure, and your blood pressure will go up if you hurt bad enough. There are times when the muscles around an injured joint or bone will change their structure to help protect that place from being hurt further. And that's why muscle relaxers are generally a secondary medication to pain medication. So you might be on Robaxin, or you might be on Flexeril to help relax those muscles around the spot of injury, because the body is trying to protect itself from being hurt worse. So those muscles lock up, which generally will cause pain in another place. There's times where if pain or injury causes the quality of life to change drastically, or something that you were able to do, you're not able to do anymore, then that can affect somebody emotionally. So antidepressants are used just as a coping, to help you cope, because maybe most of your coping mechanisms to get over things that kind of get you bummed don't work when it comes to the fact that your life has been altered permanently in a way that you didn't want it to be. So there are a lot of areas of life that pain affect and require other medications than just medications directed at making the pain stop. So, so that is, you know, that's another factor that goes into when I see people coming in pain. You know, it's one thing to hurt, and it's one thing to kind of be on the pedestal to say, well, my pain threshold is higher, so it probably wouldn't hurt me that bad. And there's lots of people that do that. People who haven't experienced chronic or severe pain in any way, are very haughty in that respect of being like, you know, oh, you just need to get over it. But to be able to be in their shoes, to see through their eyes how many areas of their life that pain has touched. It didn't just touch their body. It touched their emotions. It touched their ability to do a job, or their ability to have relationships, and their ability to participate in things that they've always participated in. And therefore it just snowballs into how they're able to respond and participate in society as a whole. So that's, you know, that's a real thing. And I know I've talked to many people with chronic conditions of all kinds, not just pain related. And I know you have too, where everybody's story is different. And one of the things they always wish is be like, just be nice to people. Like, be kind to people. You don't know what I'm dealing with. And I may not want to tell you, you know, we don't know what people are dealing with. We don't know what it's like to walk in their shoes. And I don't always know what they walk into my pharmacy carrying. I don't know what kind of burden they carry when they walk in and lay prescriptions down on my counter. So I have to give grace first. And then I have to use my professional judgment to make the best decision possible for their care. And, you know, one of the first ways is to try to develop that relationship with them. And if they're willing, then we usually will have a long lasting relationship. I actually have some, I can see the faces just talking about it, of 5 or 6 different chronic pain patients that I've developed that relationship with over the years, that because I know their story and they've opened up and told me what happened to them and how their life has been changed and how their family has been changed because of that pain, I've got a better picture of the gravity of my role in their care. And if I wasn't there and there was going to be somebody who was going to be really snotty and snobby and strict and by the book instead of me, like how their life would be different and how their care would be lacking because it would be somebody that they didn't have a relationship with.
Right. And I think this whole week and even last week, everyone that we've had on has really been speaking and preaching the same thing, is that you need to advocate to develop a good care team. You need people that are on, you know, Team Cynthia or Team Tammy or whatever, you know, whoever you are, you know, that are really in this for you. And that includes your pharmacist, to make sure that they can look at the levels of your care. And I've had so many times over the last 2 decades where a pharmacist has given me an idea. Oh, I see this, you know, maybe next time you go to your, you know, doctor, this might be an option, you know, just something to bring up. So it has given me different ideas. And so I think it's everybody working together. Also, when we talk about pain management as a whole, those doctors that do the multiple different levels, that are looking at you as a whole person, the whole picture, the whole story, not just one part of you, my back hurts or my leg hurts. They're looking at every aspect of it. I know for our children's hospital here, our like pain management teams in our clinics are pretty comprehensive in the sense that, you know, we have psychiatrists and psychologists and everybody's on board. So you are looking at that emotional aspect as well as the pain aspect, as well as the child as a whole. Because, you know, it's a very scary world when you're an adult and you need pain management on a daily basis, but it's even a scarier world when you're a little child and it's the rest of your life looking at, you know, that pain management world. So I think everything that you say, I mean, it rounds off everything that we've been talking about this whole 2 weeks. Now, when we walk away from the prescription side of it, okay, so this whole 2 weeks we've been kind of looking at what are people's favorite other modalities or products or things. Do you have anything, as being in a pharmacy for over a decade, that, you know, you're like, I really think I love this. I think it works. It's pretty unnatural, more of a natural thing that you love.
Yeah. Oh man.
Or even maybe for yourself or your own kids, you know what I'm
well,
saying?
yeah, I was thinking, so I've got 2 girls and my youngest is 3. And so I remember, when my first one was a baby and I was the first time mom, Ken was first time dad. And so we all, you know, when they're infants, you're always going for their checkups and doing things. And I remember, Jocelyn, she was a breastfed baby, and Ken took her to one of her checkups, and something came up, and he was like, yeah, she gets hiccups, blah, 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 whatever. And he was just like, it just seems unusual. I'm not used to seeing little babies with hiccups, but this is the first time a little baby's lived in my house. So whatever. And like the doctor immediately thought that was like, oh, well, you need to be on some reflux medicine, whatever. And then when we switched pediatricians, he was like, that's stupid. That's not what she needs at all. So then we went off of it. So then when Avonlea was born, we were with the new pediatrician that had at least a more,
a broader
view of like what's actually going on. And so I remember paying really close attention to a lot of like baby massage therapy.
Okay.
And my mother-in-law, who was a speech therapist, I even remember her talking about, she had a patient that actually went to a pediatric chiropractor because they had the torticollis, where like, because of how they were in the womb, their neck and their muscles were stretched a little differently. Right. And so just to help the baby adjust, there was a pediatric chiropractor that would adjust babies. And that sounds really freaky. It still sounds kind of freaky. Like, we never went, but it just kind of put this thing in my mind to say, maybe I need to pay more attention to how my baby and her whole body responds. And so I would do foot massages for her. So we never, you know, if she got really fussy, if, you know, we never had to do
uncomfortable or in slight discomfort, pain.
Yeah. Just, you know, gas pains, all of those kinds of things. I would do baby foot massage for her. And even now, like, if I bring it up, the girls, when I put them to bed, they're like, well, you do foot rubs for us. Just because it was like learning how to calm them down, learning how to, you know, and while there's some of it that seems kind of mystical and woo-woo out there, like how does a spot on your foot like affect your intestines? But it was at least something that I could do as a mom that wasn't medication, because little babies and medication, like we always know, like that there's nothing out there that you can give them that, you know. And so I remember that being, that really being something. But just, so that's little babies. That was the first time I really started paying attention to how are the parts of your body connected.
Right.
And then how can certain parts of your body affect the other one. So you may be hurting here, but the root may actually be somewhere else. So being very aware, because even now, like, I'm always recommending, like, exercise is really one of the best ways to help preserve your body.
Right.
and alleviate pain.
Pain. Mm-hmm.
I know with my long work days and standing on my feet for 10 hours, I know that if I can exercise and not just like go for a run, but actually, like weightlifting, weight bearing, like using parts of my body that I'm not using when I'm just standing up, but like doing push-ups and pull-ups and those types of things, focusing on my whole body and all the muscles that I have, really do improve. It improves my posture. It improves like the amount of back pain and the amount of foot pain that I get when I'm standing. And even when I was pregnant, and I would have SI joint pains where like the back of my hips would lock up. The chiropractor could only do so much for me because like you can only lay on your belly for so long until like you can't be in that position as a pregnant woman. And so learning how to do my own stretches and my own exercises to be able to alleviate that type of pain. But there's a lot to be said in having a strong body and being pain-free. Because when it comes to, if you're going to exercise and lift weights, you got to have good form or you're going to get hurt. But doing yoga, doing stretches, doing Pilates, doing those things that are going to benefit your joints, benefit your muscles, and they're going to benefit your mind. I'm less of a grizzly bear when I can exercise and put that emotion into something that's productive versus like being impatient all the time with everyone else around me when I've had a long work day. And so exercise in general, there's a lot to be said for having a strong body and strong muscles. And obviously if you've got an injury or you've got a type of pain that prevents a certain level of activity, there's always something that you can do. There's always going to be a part of your body that you can exercise because exercise activates the endorphins and they make your brain happy and they make you feel good. And so even if there are parts of your body that don't work like you want them to, or they're injured so they can't work like they used to, you can still work some part of your body to get some type of exercise in to strengthen your body, to relieve stress, to balance out emotional chemicals and hormones, and to release some endorphins to make you feel good. So
yes. And we know that exercise and movement helps relieve pain. So that's why after you have like a huge surgery, you get a new hip, they want to stand you up the same day half the time, because the more you move and get your joints moving, the less pain you're going to have. And this week we talked about some yoga, different balls and things you can use at home, as well as chiropractic care. One of the other things I was going to say, I might drop the link below. There's an amazing massage book for little babies and younger children. I don't have the author's name on my head, but I know we had a neuro massage therapist on a few months ago, and she had given me the name of the book. And it's a book that as a layperson, you can just purchase it to kind of follow along. But those bottoms of the feet, yes, they take in everything. So that is awesome for all of those tips. So on this beautiful Friday in Georgia and this ugly Friday in Wisconsin, any last words you'd like to leave us with?
Oh man.
I know I put you on the spot right now.
Shirt.
Oh, we didn't do your shirt. That's what you listen.
Trust me, I'm a doctor.
I love it.
I have to say, it is funny trying to explain to my kids. They're like, "You're not a doctor." I was like, "Well, I wear a white coat at work and I give people shots." So, but it's one of those things where I really do care about people. And it's like, and I always want to be able to tell people, be like, if your pharmacist is not good to you, call me. Like, I will be your replacement pharmacist. You might not be able to drive all the way to Georgia to get your medicine from me, but I will listen. I will be comforting to you. I will be respectful of you. Like,
and so where can they find you? Where can they all find you at?
Yeah. So I am at Farm Answers Pod on Twitter. It's the Pharmacist Answers Podcast on Facebook. That's my Facebook page. And which my wonderful microphone was out of commission for a couple of weeks. We had to ship it to California for repairs and got it back. So I have been behind on episodes, but I've got some new things coming up that I hope everyone's going to enjoy. So following me on the Pharmacist Answers podcast Facebook page will be the best place to see those updates. And my website is intelleximed.com. INTELLEXIMED, Intellexymed. And there's a contact link there, a feedback link there. Podcast is there. Some other blogs and things that I've written that are just like text-based and not video or audio-based are there. So, because when it comes to pain and the pain medications, just from the pharmaceutical side, like we could do a 6-week clinic. Like we could be here forever. Just because it's so intricate and it's so different, and the parts of your body that are affected it's really a broad whole body type of therapy. And if doctors could understand that, then they're going to be the doctors that do understand that are going to be the doctors that are going to take best care of you. So
right, and trust you because you're a doctor. That's and you'll drop all your links below, right? Any of those other things. And when we talk about the different type of podcasts that Cynthia has on her show, she has things like about laryngitis, like, I mean, all of our medical ailments that we have. So an amazing resource. So we'll drop the link below so you guys can head on over there. And I thank you for spending, I don't really know how long we've been on because me and you always talk like forever. So it might have been.
And we were late and things broke and then we fixed them. So yeah, who knows?
Who knows? But I hope that you guys all have a fabulous weekend. For all the mothers out there, grandmothers, puppy mothers, everybody who is any type of mother to anyone, happy Mother's Day. And thank you, Cynthia. Again, make sure that if you guys need to find any of our tutorial videos or podcasts, head on over to onairadvocate.com. Also, our chronic pain and pain management series will carry through the end of next week. So make sure to stay tuned for that. And as I've been saying at each of every episode, we are launching our private On-Air Advocate community in June 1st, about June 1st, June 2nd, somewhere right there. So make sure that you request to be a part of that because we will all be in there to ask questions on a regular basis. So on that note, have a blessed day, everybody.
Bye.
Take care. Bye-bye.